Hello, my name is Azalea, and this is again another project for one of my classes towards my degree, particularly my early childhood and family studies class. And for this quarter-long equity project, we were asked to choose one community or cause that we care about and investigate both the problems and possible solutions. I chose to focus on children's access to trauma-informed and, most importantly, nature-based mental health care, particularly outdoor therapy. I am interested in becoming a childhood developmental therapist, and I've also been working at the Fiddleheads Outdoor Preschool, sponsored by the UW, where outdoor learning and environmental healing are really core values. This project is my way of exploring how outdoor and child-centered therapy actually works and why it matters for kids who've experienced trauma, depression, or just need any extra help. And also why so many families who could benefit from it still lack the access to it. So let's begin with addressing quickly what outdoor childhood therapy actually is and why it's different from traditional adult therapy. Child therapy means mental health treatment designed for kids. Kids don't typically process feelings in the same way that adults do, and certain children can't just sit in a chair and talk through their problems for hours. That means that child therapy often uses play, movement, and activities to help kids show what's going on inside, as well as learning regulation and building skills. And the therapist still has the same goals and still tracks their progress. They still use evidence-based methods, and the difference from adult-based therapy is mostly the format. Kids communicate through action more than conversation in therapy. And traditional child therapy usually happens indoors in a clinic or an office, and that indoor setup is usually more heavily controlled. Same walls, same lighting, same toys, same noise level, and a lot of children do fine with that, but some don't. Some kids get restless or shut down in a small room. Some get overstimulated, and some just don't engage because the space feels too medical or artificial, and they feel too shy or afraid to show their true feelings. Outdoor child therapy is the same kind of therapy, like the same clinical purpose, but done in a more natural setting instead of like in a clinic. This could be a park, garden, woods, or any type of outdoor play space. It's just moving therapy into a place where the child can be more physically active and less boxed in, more creative. A peer-reviewed article by Swank and Shin entitled Nature-Based Child-Centered Play Therapy, an Innovative Counseling Approach, describes this clearly. In nature-based play therapy, they quote that nature is the playroom and natural materials are the therapeutic toys, meaning that the environment becomes part of the therapeutic tools. It's not just like the backdrop that changes when you go outside, because that's not the goal, it's more of the medium. Indoors, a therapist might work on regulation or problem solving through toys on a table or a sand tray or role play. Outdoors, the same goals get worked on through real movement and real situations, like a child balancing on a log is doing motor planning, confidence building and frustration tolerance. A child building something with sticks is practicing planning, flexibility, and persistence. The therapist is watching for the same clinical targets, they're just showing up through more natural activity instead of purely indoor tasks. The shift outdoors is also sensory input. Outside has changing light, wind temperature, uneven ground, bugs, textures, sounds, and for a lot of kids, especially like neurodivergent kids, this helps aid in therapeutic regulation in a way that a clinic can't always copy. Outdoor therapy also makes certain social skills easier to work on because kids do naturally better outside or in a less clinical setting. In small outdoor groups, kids can negotiate roles, solve problems, deal with conflict, and repair relationships while actually doing something that the therapist can guide them in while the child still stays engaged. And specifically play therapy does not need to be strictly outdoors only necessarily, because not every child can do outdoor therapy every day, all the time. And some kids also have medical or mobility needs, some have sensory limits that make open environments just too much. And that's why programs like Good Nature Therapy talk about blended models. Good Nature Therapy knows that sometimes indoors, sometimes outdoors, or bringing nature materials inside so the kids can still get the nature-based benefits without losing access is also very important as a blended model. So this moves on to the question, does outdoor therapy actually change anything? And according to multiple programs and case studies and reports, yeah, it does. And studies and documented outcomes show measurable differences in kids' behavior and mental health and how they function, not just during therapy, but after it too, which is the most important part. Because in one review by Stia et al., entitled Mapping the Concepts, Content, and Outcome of Family-Based Outdoor Nature Therapy for Children and Adolescents with Mental Health Problems, which is a family-based scoping review, they say that family-based outdoor programs showed things like increased self-concept, better family communications, reduction in problematic behavior, more social engagement, and improved school performance. These kinds of outcomes aren't just reported in one place either. There are programs like Contigo and Treeline Enrichment and Adventure Me, and also Good Nature Therapy, which are services that all describe similar patterns in outdoor therapy. Kids with sensory, motor, or emotional regulation challenges, especially neurodivergent kids, showing more flexibility and better communication and stronger peer connection outside than in a standard clinic room, is shown to have positive results. Treeline Enrichment in Florida blends traditional occupational therapy with nature-based experience and treats them as more of an active partner in the outside realm. In child development with one-on-one outdoor OT sessions and group forest play. Parents report improvement in regulation, coordination, confidence, and their kids actually like going, so they don't have to drag them out of bed every day to go. Adventure Me is also a forest school in Colorado which served children with special needs in a fully outdoor school model where they quote, "Nature is the classroom, no blackboards, no desks, no pesky fluorescent lighting." The outdoor environment supports regulation and social and emotional development through natural textures, uneven ground, open space, and peer interactions. This also leads us to Good Nature Therapy Services in Ohio, which offers that hybrid indoor-outdoor campus with spaces for climbing, digging, sensory garden exploration, walk walls, hammocks, and mats for calm transitions. And it also, most importantly, uses a blended approach so more kids can access the nature-based therapy while also leaving room for more indoor and more bodily accessible means of therapy. And this is where we hit a wall, which is just access for these kinds of therapeutic means. Because outdoor therapy works, it helps with regulation, social connection, participation, kids who need extra help, kids with sensory differences, ADHD, anxiety, they show up more and they engage more and they carry those gains back with them into school and home. But most families who need it usually never get close to be able to get it. And that's not because the therapy doesn't exist, as we've seen in the reports, but it's because the system doesn't necessarily support it. Because right now, the main barrier is money. One policy review out of the Washington state looked at the wilderness type programs and tried to do a cost-benefit analysis. And they literally said that they were, in quote, "were unable to conduct a meta or benefit cost analysis because studies did not meet our standards of methodological rigor," which means that they just couldn't clearly prove cause and effect. Because if you're a state agency or an insurance company, that's kind of a hard stop because they want and they need clean and clear data before they can fund anything long term for them. But at the same time, though, the costs are huge without this. That review also estimated that families are paying, and I quote, a daily rate of about $5,058 plus a one-time fee of a little over $3,000. And in 2020, that works out to be around $20,000 per person for a 30-day program and about $53,000 for a 90 days. And health insurance does not cover outdoor therapy programs, which means that most families are on the hook for like the full amount, and combined high cost also with no coverage, and you get exactly what we have now. We have programs like the ones I mentioned that do exist that help kids and that are completely out of reach for the average family. The data also shows a clear bias in who gets served, which is mostly white middle to upper class families with very little tracking of racial or economic diversity whenever they do a lot of these studies. Meaning, what would it actually take to make this accessible? First, obviously, clearly, we need better research. Not in like the abstract, but tied directly to funding decisions. The Washington State team basically laid out a path, especially because of how many nature schools we have here, and they say that if future studies can show clear and causal effects on things like depression, future substance use, or functioning, then we can link those changes to real-world outcomes like education and earnings. And then once we can demonstrate if the benefits of the program outweigh its costs, then you can have a case for public investment. But right now we don't have that level of proof for outdoor programs as a category. But we do have it for the clinical approaches often inside them. Treatment models like cognitive behavioral therapy and family therapy already have strong evidence in traditional settings. CBT, for example, has solid support for adolescents with depression, anxiety, and ADHD, and its benefits, and I quote, are likely to exceed program costs over 90% of the time for any outdoor therapy program. And family therapy models also show reduction in substance use and disruptive behavior. So the clinical side is already justified, but the setting is lagging behind in its research. But if we design more outdoor programs that clearly use these proven methods and then study them well, we're not asking policymakers to fund something vague, as they say. We're asking them to fund evidence-based treatment in a different, but for some kids, better and more healing environment. So part of how do we make this possible is fairly basic. We put that evidence in front of people who control money and systems in a way that they can understand. And that might mean breaking down results in plain language for classmates, teachers, parents, policymakers, turning them into short videos or infographics, or writing one-page summaries that connect the dots. And here's what the programs do. And here's what changed for the kids and families, and here's what's missing in terms of the access. And from there, you can start to ask for specific next steps, like more funding for research with stronger designs, and pilot funding to try outdoor-based models in community or school settings, and eventually policy changes that let the programs be treated as real mental health services instead of like extras that nothing will cover. And petitions to emails and local representatives and public comments on education or mental health plans are more effective when they're already backed by concrete examples and data instead of just nature is good. Which means the bottom line for most of all this is that we don't need to wait for the research to be perfect before we start pushing for change. We already have enough studies and real-world programs to show that trauma-informed outdoor therapy helps kids regulate, connect, function better at home and at school, and it can strengthen families, not just individual children. So we don't have like major gaps in ideas. It's in visibility, priority, and political will. And the more people understand what these programs actually do and who's currently shut out of them, the harder it is for funders and policymakers to pretend that they're optional. And thank you for listening.